Hi, everybody. I'm Amy Strong. I'm a nurse practitioner here at UVA, and I just want to thank you guys for the opportunity to share some of the work that Lauren and I and our lung cancer screening team have been doing in the space of telehealth. So picture this, a narrow, winding road in the mountains of Southwest Virginia. It's early morning, and the fog still clings to the ridgeline like a worn-out wool blanket. And a small one-story house with a rusted metal roof, 63-year-old Carl Johnson stirs his coffee with hands stained from decades of coal mining. His breath is shallow. He coughs a dry, rattling cough, but he brushes it off. It must be the mountain air, he tells himself. Carl hasn't seen a doctor in over 5 years, not because he doesn't want to, but because the nearest clinic is 90 minutes away. And he doesn't drive much anymore. His truck's unreliable. Gas is expensive. His wife passed away a few years back, and his daughter lives in Kentucky with kids of her own. Carl started smoking when he was about 14. Like most folks in his town, cigarettes were just a part of life. His dad smoked, his uncles smoked, and signs on the gas station still advertise Marlboros for about $4.49 a pack. He's heard about lung cancer screening. There was something on the news once, but no one he knows has ever had it done. He figures it's for city people with good insurance. Then one morning, Carl wakes up and he can't catch his breath. He collapses in the bathroom, and ultimately his neighbor calls 911. After 2 days in the regional hospital, he gets a diagnosis. It's stage 4 non-small cell lung cancer, and it's spread to his liver. Carl looks at the doctor and asks the question that no one wants the answer to. If we'd caught it earlier, could we have made a difference? And the truth is, yes. If Carl had gotten screened 2 years earlier, they likely would have found a smaller tumor, maybe stage 1. It could have been treated with surgery or radiation, and he might have seen his grandkids graduate. But no one offered him screening. No one explained that based on his smoking history, he was at higher risk for lung cancer and that there was an easy screening test for this. No one reached out. And Carl's story is not rare. In fact, in rural Appalachia, it's painfully common. Lung cancer screening is the leading cause of cancer death in the United States. But here's what hits hardest. Appalachia has some of the highest smoking rates and the lowest access to care in the country, especially in the rural counties, as we've all talked about all day long. Cancer mortality in Appalachia is 10% higher than the national rate and 32% higher in central Appalachia. And while there's a proven way to catch lung cancer early, which is lung cancer screening with low-dose CTs, the truth is most people who qualify never get screened. Why? Well, there's a lot of reasons. You guys have touched on a lot of those today. There's lack of transportation. There's few, if any, local providers that are educated and offer lung cancer screening. There are complex eligibility rules that make it challenging. And let's not forget the stigma. Many people here feel judged when they admit that they still smoke. So enter telehealth, and not just Zoom calls. I'm talking about an integrated, culturally sensitive, tech-enabled lung cancer screening program designed for Appalachia. And here's how it can work. A local nurse or community health worker identifies high-risk patients, people ages 50 to 80 with a heavy smoking history. Instead of driving for hours, the patient can connect via video or phone with a nurse practitioner trained in lung cancer screening. There's no fancy setup. It's just a phone and a quiet room at their local clinic or library or shed in the yard. And they can meet with the nurse practitioner to talk about the risk and benefits, have the shared decision-making conversation, which is a required step in lung cancer screening. And if eligible and willing, patients are scheduled for a lung cancer screening CT chest, or perhaps a mobile lung cancer CT unit comes to their town once a month for screening. It sounds kind of simple, but there are a lot of challenges with lung cancer screening. It's time consuming for primary care providers who are already trying to get so much done in a short 15-minute visit. There's confusing eligibility requirements. There's cost and insurance coverage issues. To help with this, we developed a lung cancer screening telehealth program. In 2016, we received grant funding from the Virginia Tobacco Revitalization Commission, which allowed us to start a telehealth program with Buchanan General Hospital in Grundy, Virginia. The locals call it Buck General. Buck General is a small independent hospital that a lot of you may know, serving areas in Virginia, Kentucky, West Virginia. We created an interdisciplinary team with administrators and clinicians and telemedicine analysts and marketing to have the goal of providing patients access to lung cancer screening in their own community without having to drive for hours and miss work and pay for gas and food and lodging.
So you remember all those heat maps that Aimee had up on the screen for smoking rates, incidence of lung cancer and lung cancer mortality. Well, look at how few and far spread out the lung cancer screening sites in this area of Appalachia are. On the winding roads, we talked about this all day long too, but on the winding roads of rural Virginia and West Virginia, you can expect that a facility that's 25 miles away will take you 50 minutes or more to get to. Buck General was strategically selected in this area where we knew we needed more lung cancer screening and had high smoking rates. So everyone, please meet Marty. You heard us talk about Marty earlier. Robert knows Marty, and Marty and he have worked together in Grundy, Virginia. But Marty is the director of radiology at Buck General. He's a lifetime resident of Grundy, Virginia, and he's passionate, to say the least, about lung cancer screening. Like most of Appalachia, when patients arrive for care at their local community hospital, it's their neighbor or distant relative that works at the front desk, or in this case, runs the radiology department in the community hospital. Marty went to high school with most of the local medical providers and many of the patients that come into their community hospital. As Aimee mentioned, we used our grant funds to set up this telehealth lung cancer screening program at Buck General. Patients arrived, they were placed in a room in front of a computer and then connected for a secure private telehealth visit with Aimee, who was here in Charlottesville at UVA. And she would talk to them about lung cancer screening. During that same visit, the radiology tech would then escort that patient from that small room next to the computer to the low-dose CT machine. And the CT would then be read and resulted here at UVA by radiologists that are trained in lung rads. And then those patients, any follow-up care that they need to get, would get there in their local community, but all the navigation was happening here in Charlottesville at UVA by our nurse navigators, helping those patients make sure they get follow-up and annual screening, and in addition to navigation if they needed services. It's a great program. We had some amazing success, but we also had some challenges.
Oh, sorry. I'm not really good at this.
You're great at it. Yeah. There we go. Just 2 fingers like that.
Oh, gotcha.
Okay, good. Okay. So providers weren't really sure who was eligible. We struggled with having them add just one more thing to their clinic visit. They weren't sure how to refer to our program. They were frustrated with the time that it took from referral to actual screening. Patients were really hard to get on the phone and get scheduled. They didn't understand why a 434 Charlottesville phone number was calling them, and they for sure thought it was spam and weren't answering our calls. And if they did figure it out, why was a provider or scheduler over 5 hours away from them calling them to schedule their lung cancer screening? We also had a high rate of patients just not showing up to their appointments. They probably thought the whole thing was a scam. So in 2023, we partnered with ACCC and became involved with the Rural Appalachia Lung Cancer Screening Initiative. We used this project to directly address some of the challenges that we were experiencing with this telemed program. We worked with Buck General. We co-branded patient-facing and provider-facing education materials. We placed banners up in primary care offices and at the local grocery stores, evidently, in the pharmacy there. We had no idea, but that's amazing. And we developed a webinar that we delivered virtually for primary care providers, educating them on lung cancer screening, providing them with the tools for shared decision-making, and how they could actually bill for that time with their patients. We developed lung cancer screening packets for primary care providers that contained everything that they needed to do or needed to know to direct order these patients into screening, so they didn't even have to be scheduled by UVA. Back to Marty for a moment. He knows those winding roads like the back of his hand. And remember, he went to high school with many of these providers. So he personally drove to all of the referring provider offices. He installed the banners and he distributed our materials. If a provider didn't show up for one of Aimee and I's training, Marty called them to remind them about how much easier it was going to make their lives if they just came for our 15, 20-minute webinar. Funny story, one of our partners that went out to deliver marketing materials and all these materials with Marty likened being a passenger in his car on the back roads of rural Virginia and West Virginia to being on a roller coaster. So after completing the Rural Appalachia Lung Cancer Screening Initiative project, it was centered around patient and provider education material and scheduling. Hold on one second. And scheduling and changing out our scheduling to be performed at the local level. So we were actually able to increase our baseline screening by 280% and increased our annual scans by 360%. So it was very, very impactful. Additionally, we doubled the number of referring providers into the screening program. So this isn't just about lung cancer, as we've been talking about all day. It's about equity. It's about bringing 21st century medicine to the 20th century zip codes that have been left behind. It's about using innovation, not just to impress, but to actually include. It's about finding the local champion in the community to bring people together. We should look for a Marty in every community that we go into and that we try to help. What if the next great public health success story didn't happen in a big city hospital, but in a borrowed church basement with a nurse's iPad, a shed, any of those places? If you're a policymaker, fund telehealth and mobile screening in underserved areas. If you're a provider, advocate for your rural patients and build bridges with tech and larger healthcare institutions. If you're from Appalachia, know this: your story matters, your life matters, and you deserve the same shot at early detection and survival as anyone else. Lung cancer screening saves lives, and with telehealth, we can finally make those lives count, no matter where they come from and where they call home. Thank you.